All right, welcome back. So the test went pretty well on Monday. I think the class average was a 78, which is much higher than the first test. I think the highest score is a 95 and the low is a 51. So overall, the grades were a lot more closely clustered, which was good, and that's also part of the reason for the higher class average. That was good. So we're almost there, home stretch now. So you got one test left, plus the final, and then one more lab quiz, and then the pathology paper. Don't forget about that. So then we're done. And we also only have, including today, 5 live classes left, and then we're home for Thanksgiving. So then we'll be fully online. So questions or anything? Nope. All right. So let's move on to the lower leg and foot. We're going to be following pretty closely to the Lab 7 sheet. Essentially, I think we're going to do the first half of the Lab 7 sheet, and then we're going to build on it a little bit too. So let's move on. There we go. All right, so let's talk about the lower leg. So we left off the last time we were talking about orthopedic stuff before we got into the brain. We left off talking about the knee. So now we're going to move distal to the knee. So in the lower leg, there's 2 bones. So you got the tibia and the fibula. And so of those 2 bones, the tibia is the larger of the 2. It's the weight-bearing bone. And then the fibula is the smaller of the 2. It is a non-weight-bearing bone. So one of the important things to know, the tibia is medial, so it's on the inside aspect of your lower leg. The fibula is lateral. So in this case, you're looking at the right lower leg from the front. So again, I'm always using the right side. So you're looking at the right lower leg from the front. And so obviously then, this is your tibia, the medial of the 2, and then this little guy over here is the fibula, the lateral of the 2. So the tibia and the fibula are connected by fibrous joints. So ideally, those joints don't move. So thinking way back to when we talked about joints, remember that there were different types of joints. Some of them moved a lot, some of them moved a little bit, and some of them didn't move at all. So ideally, the interactions between the tibia and the fibula, so proximal and distal tibiofibular joints, ideally those don't move. So proximally, you've got anterior and posterior ligaments of the fibular head. So that one that's highlighted in green there for you is the anterior ligament of the fibular head. You don't need to know either of these. I won't ask you questions about either of these, so this is more of an FYI. But there are anterior and posterior ligaments of the fibular head. There's the posterior one. And then distally, this one I do want you to know. So on the distal aspect, there is the anterior inferior tibiofibular ligament, or AI-TFL. And then on the posterior aspect, there's the posterior inferior tibiofibular ligament, PI-TFL. And of those, the AI-TFL is the one I want you to know, because as we'll talk about here in a minute, the AI-TFL is one that is commonly injured in, or the one that is injured in high ankle sprain. So the fairly commonly injured ligament, and you might run into injuries of it. So the anterior inferior tibiofibular ligament obviously connects the tibia and the fibula, and it tells you where it is, right? It's anterior, it's in the front. Inferior, it's closer to the bottom of the leg. And then, like I said, that's the one that's highlighted in green there for you. And then the last thing on there is the interosseous membrane. So obviously interosseous means between bones. We had an interosseous membrane between the radius and the ulna and the forearm. And we have one in the lower leg. So the one in the lower leg is highlighted in green there for you, but it's not super obvious because it's kind of a ghost-like structure, but it is a little bit green there on that picture. That's the interosseous membrane. So it's a sheet of fascia or connective tissue that runs between the tibia and the fibula. What's the purpose of the interosseous membrane, do you think? Anybody know? Fills in a gap. The primary purpose is that it serves as a site for muscle origin. So tibialis anterior, tibialis posterior, soleus, one of the long toe muscles also originates on there. So site of muscle origin is going to be the primary purpose of the interosseous membrane. But again, just a thing to know, it's a sheet of connective tissue that runs between the tibia and the fibula. All right, so now we're definitely on that Lab 7 sheet. So osteology of the tibia. So landmarks I want you to be familiar with. The first is the medial condyle. So the medial condyle, and actually I'm going to pull up the superior view. There we go. So what you're looking at in this second picture that popped up. So this is obviously a superior view of the tibia. So this is the medial aspect of the tibia that I'm mousing over there. This is the lateral aspect right here. And so those are the two condyles. The larger of the two is the medial condyle. The smaller of the two is the lateral condyle. And so what do the condyles do? Well, they interact with the condyles of the femur so that when you're standing up, when your knee is in extension, the medial condyle of the femur sits on the medial condyle of the tibia, lateral condyle of the femur on the lateral condyle of the tibia. So they help transfer weight from the tibia to the femur and vice versa. So they actually distribute weight between the tibia and the femur. That's the job of both of those condyles. And again, another relevant thing to know is that the medial condyle is larger than the lateral condyle. So on this anterior view, then the medial condyle is on top up here, and then the lateral condyle is over here. All right, the intercondylar eminence. So it tells you where it is, intercondylar, between the condyles. And an eminence is some sort of a rise in that area, right? So the intercondylar eminence is a raised area here, kind of in the middle, in between those condyles. And the significance of that, remember that the ACL, the anterior cruciate ligament, inserts in front of that, and the posterior cruciate ligament, the PCL, inserts behind that, or posterior to that. And then the tibial tuberosity. So the tibial tuberosity, on our anterior view, it's this really obvious area here. And it's pretty easily palpable in most of us. Most of us have a relatively obvious, fairly large knob on the front of our chin, and that's your tibial tuberosity. We've actually talked about that landmark a few times before. What's the significance of that landmark? What inserts there? Remember, David? Yeah, the quads, right? So the quadricep group inserts via the patellar tendon or the quad tendon into the tibial tuberosity. And we also talked about it from an injury standpoint. Remember Osgood-Schlatters disease, that apophysitis, that occurs there, the tibial tuberosity as well. So the significance, the thing to know about tibial tuberosity, insertion of the quadriceps group. Gerdy's tubercle. So Gerdy's tubercle is actually fairly obvious on this. It's at about a 45-degree angle to the frontal plane. It's kind of this angled surface over here on the lateral aspect of the tibia. So what inserts a Gerdy's tubercle? Remember that one? David? IT band, very good. So the iliotibial band, or IT tract, but I'll always refer to it as band, the IT band inserts at Gerdy's tubercle. So remember that that's just distal, just below, that lateral condyle of the tibia. And the two muscles that insert into the IT band, of course, are TFL and glute max. Then on the medial aspect, so if Gerdy's is over here, my mouse comes up, there you go. So if Gerdy's is over here on the lateral aspect, then the pes anserine is over here on the medial aspect. So the pes anserine is kind of in this area here. So if you look at the Netter drawings, on the medial aspect of the tibia, there's these three blue stripes. Those are three muscles that insert there in that area called the pes anserine. Anybody remember those three muscles? Yeah. Okay, so one of the hamstrings, so semitendinosus, good. Inserts there, so semitendinosus is one of the three. And then the other two are sartorius and gracilis. So sartorius, that really long muscle, the longest muscle on the body. Gracilis is the most medial of your groin muscles. So sartorius, gracilis, and semitendinosus all insert there at the area of the pes anserine, which again is just medial to that tibial tuberosity. The soleal line is on the posterior aspect of the tibia. So if we flip it around, the soleal line is this. So that is part of the origin of the soleus muscle. Soleus is S-O-L-E-U-S. S-O-L-E-U-S, soleus. So the soleus muscle originates along that line, but also along most of the posterior aspect of the tibia, and then also onto that interosseous membrane. So the soleus is one of your calf muscles. So the superficial calf muscle is gastrocnemius. We've already talked about that one. Soleus is deep to that. The soleus then originates there along the soleal line, among other areas. All right, the medial malleolus. So the medial malleolus is, colloquially, your inside ankle bone. So that big knob on the inside of your ankle, that is your medial malleolus. And that is the distal projection of the tibia. So if we look at a medial view of the tibia, so now you're looking at the right tibia, medial view. So all of this down here is the medial malleolus. And one of the significant things about that is that helps stabilize the ankle complex. It helps keep you from dislocating, specifically your talus, which is one of the tarsal bones. So for now, just know your medial malleolus is your inside ankle bone. Then we got the fibular notch. So the fibular notch is on the lateral aspect of the tibia. So I'm going to switch views. Now you're looking at the lateral aspect of the tibia, and you can see these two areas. Here's the proximal one, and then here's the distal one down here that have hyaline cartilage, or articular cartilage, to allow for the interaction between the fibula and the tibia. The fibular notch, though, is on the distal aspect. So there's a little indentation on the lateral aspect of the distal tibia to allow for good interaction between the tibia and the fibula. The fibular notch is on the lateral aspect of the distal tibia. It's a little indentation. And so by having that notch there rather than a flat surface, that helps stabilize that distal tibiofibular joint. And then the inferior articular surface, obviously, is down below. An articular surface is where we have the interaction of two bones. So I didn't pull up an inferior view of the tibia, but the inferior articular surface is down here. It's just the most, other than the medial malleolus, it's the most distal aspect of the tibia. So you have hyaline cartilage lining this distal aspect, and so that's your inferior articular surface. The fibula, fewer landmarks that I care that you know, and the first three are all proximal. So what you're looking at here, it's an anterior view of the right fibula, but all of these things are easier to see from a lateral view. So now we switch to a lateral view. So now you're looking at the right fibula from the lateral aspect or from the outside. The first one on there is the apex. And so the apex is this very top point up here. So it's actually not super obvious on the anatomy app, but it is on the bones that we have in the lab. Your apex is typically pretty obvious, but like I said, it's fairly dull there. But the apex is the most proximal aspect of the fibula. And then we got the head, which is all the rest of this. So the apex is kind of an offshoot of the head of the fibula. Again, all this stuff is the head. And then where it narrows is the neck. Then we have the diaphysis, which is all of this. And then the last thing on there is the lateral malleolus. So that's this. So if the medial malleolus is your inside ankle bone, well, then the lateral malleolus is your outside ankle bone. So between those two, that helps make up what is called the ankle mortise, or sometimes referred to as the ankle socket. All right, so between the medial malleolus, the articular surface of the tibia, and the lateral malleolus, that makes up that socket, or part of the socket of the ankle complex. All right, so let's talk about bones of the foot. So again, right foot, now you're looking at a superior view. So the tarsal bones are very similar to the carpal bones. So remember in the hand, you have 8 carpal bones that help make up the wrist. All of those are short, irregularly shaped bones. Actually, they're not irregular. All of those are short bones, right? Similar concept in the foot, except there are 7 of them, not 8, and they all make up the posterior aspect of the foot. So the 7 tarsal bones are the short bones on the posterior aspect of the foot before we switch to the long bones, which start with the metatarsals. So first things first, the calcaneus. So your calcaneus is your heel bone, so it's back here. So all of this is the calcaneus. It's also, as you would expect, the largest of your tarsal bones. So know your calcaneus is your heel bone. Then we have the talus. And so the talus sits on top of the calcaneus. And the other important thing about the talus is that it interacts with both the tibia and the fibula. So if we look at the foot from in this case, we're looking at a medial view. So there's an inside view, medial view of your right foot. So then the talus, here's you don't have to know the parts of the bone, but this is called the talar dome. And you can see all this articular cartilage. So that top of the talus, that dome, is what's actually going to interact with that inferior articular surface of the tibia. And then we have the talar head, just down here, interacts with the next bone, which is the navicular, this bone, and then there's a neck in through here. So the talus sits on top of the calcaneus, interacts with the tibia, and then also will interact with the navicular. Switch back to my superior view. So moving distally from the talus, so again, all of this is the talus. Moving distally, now we're on this bone, which is the navicular. So the navicular, by itself, kind of looks like a boat. You can see this is a recurring theme in bone naming. And so this one kind of looks like a boat, and so that's where the name navicular comes from. So the navicular is going to be important in that it helps us in assessing whether or not somebody has fallen medial longitudinal arches. Your medial longitudinal arch is the primary arch of the foot. And so one of the ways that we assess that, and if one of the ways that we can assess if the foot is actually too mobile or not quite mobile enough, is to look at the medial projection from the navicular. It has a tuberosity, which is this little projection here. And so that's a landmark that we'll actually mark with a Sharpie and then have them do a couple of weight-bearing and non-weight-bearing tests to look at the movement of the navicular. So the navicular interacts with the talus. And then moving distally from the navicular, we're going to move on to our medial cuneiform. So there's 3 cuneiforms. So the medial cuneiform is here. So obviously it's the most medial of them. It's going to interact with the big toe. So here's the medial cuneiform. Then we have the intermediate, the one in the middle, and then the lateral cuneiform. So 3 cuneiforms, medial, intermediate, and lateral, and they interact with the first, second, and third toes respectively. And then on the lateral aspect, we have the cuboid. And so this is the cuboid over here. It's going to interact with the calcaneus, but it also interacts with the 4th and 5th metatarsals. So it's a lot like the hamate in the hand. Remember that the hamate in the hand interacted with the 4th and the 5th metacarpals. Same concept in the foot. Cuboid interacts with the 4th and the 5th metatarsals. And as an aside, as I was going through this before class, I realized that cuboid is not on the slideshow, so I added it. So if you printed out the slideshow, or if you pulled it up, cuboid is not on there. So make sure you add cuboid. I don't know why I forgot that as I was making the slideshow, but I did. All right, so there's medial view, lateral view. All right, so let's talk about the metatarsals. So the metatarsals, obviously are highlighted in green there. And so the way the numbering works, the foot works just like the hand, right? So in the hand, remember that your metacarpals, the long bones of the hand, are numbered 1 through 5. The thumb is number 1, pinky is number 5. Same concept in the foot. Your big toe is number 1. Your pinky toe is number 5. And so the metatarsals are the long bones of the foot. They make up most of the foot. And the one that interacts with the big toe is number 1. The pinky toe one is number 5. In terms of terminology about them, they do have heads and bases. So the bases are proximal and the heads are distal. So whenever you stand up on your tippy toes, you are standing on the heads of your metatarsals. Where the bases come in, sometimes you can have problems with the interaction of the base and their closest tarsal bone, or a really common injury is a fracture of the base of the 5th metatarsal. And so you can get different kinds of fractures on there. There's a fracture that results when somebody steps on the foot, or there's a muscle that inserts there into the base of the 5th metatarsal. It's one of the ones that keep you from really spraining your ankle quite as badly. It everts the foot. We'll talk about what that means. But that muscle is peroneus brevis. So that's where we'll talk about the base, particularly the base of the 5th. So base is proximal, head's distal. And then the phalanges, so just like in the hand, where your finger bones, each an individual is a phalanx, and there's 3 for digits 2 through 5, and only 2 for digit 1. Same concept in the foot. So you have 2 phalanges for your big toe, and then 3 phalanges for the rest of them. So on all the toes, you're going to have a proximal phalanx, and so the proximal phalanx of 1 through 5 is highlighted there for you, so the close bone. And then digits 2 through 5 have a middle phalanx, but again, because number 1 only has 2 bones, it doesn't have one. So there's our middle phalanges. And then we have the distal phalanx, which all 5 are going to have. The distal phalanx, the far one. Even your pinky toe has a 3rd bone out there. It's tiny, but it does have 3. All right. Talocrural joint. So now getting into the bones of the foot, or sorry, the joints of the foot. So the ankle complex per se usually is discussed as having 2 joints. The first of the two of the ankle complex is the talocrural joint. So as you can see there, the talocrural joint is formed by the interaction between the tibia, the fibula, and the talus. So you've got, again, right foot anterior view. So here's our medial malleolus. Here's our inferior articular surface of the tibia. Here's our fibula and our lateral malleolus. And then here's the dome of our talus. So tib, fib, talus form that talocrural joint. That space that the talus sits in is also sometimes referred to as the ankle mortise, M-O-R-T-I-S-E. You can see that as well. So the thing that I want you to know is that at the talocrural joint, you get two actions. And those actions are plantar flexion and dorsiflexion. So plantar flexion is when you come up on your toes. Dorsiflexion is when you do like a calf stretch. You bring the top of your foot toward the front of your shin, toward your tibia. So calf stretch is dorsiflexion, and then stand up on your tippy toes is plantar flexion. So what happens there is as you plantar flex, the talus is actually going to slide out from underneath the tibia a little bit. And then as you dorsiflex, it slides fully under the tibia. So the talus slides back and forth, out from under, or completely under the tibia, depending on whether you're in plantar flexion or dorsiflexion. So those are the two motions that occur there at the talocrural joint. And then the other joint that's usually grouped into the ankle complex is called the subtalar joint. And so it tells you where it sits. Subtalar means below the talus. And so at the subtalar joint, we get two actions. You get inversion and eversion. I should probably talk about the bones first. So the two bones are the talus and the calcaneus. So as mentioned earlier, the talus sits on top of the calcaneus. And so on this depiction, your subtalar joint is the interaction between, so obviously then this is your talus up here, this is your calcaneus or your heel bone down here, and so the subtalar joint is this little squiggly line right here. So it's below the talus, and it describes the interaction of the talus and the calcaneus. That's your subtalar joint. So the two actions that occur there, inversion, eversion. Inversion is where you take the bottom of the foot, rotate it toward your midline. So the bottom of your foot comes toward the midline is inversion. Eversion is the opposite. Take the bottom of your foot, rotate it away from the midline. So those actions then occur at the subtalar joint. Okay. So the ankle complex then is typically referred to as the combination of the talocrural joint and the subtalar joint, because you get that combination of plantar flexion, dorsiflexion, and then inversion, eversion. All right. So case study. I'm going to show you a video real quick. You'll know what happens. It is pretty obvious. All right, so no sound, but we don't need sound. You're going to watch this player's left ankle as he drives to the hoop. He's going to step on the other guy's foot. And better angle. Steps on the other guy's foot. All right. So, pretty common injury. What do you do? Sprained his ankle. The more colloquial term, of course, is that he rolled his ankle. But what we mean is that he has a lateral ankle sprain, also sometimes referred to as an inversion ankle sprain. So you'll see both terms and they mean the same thing. An inversion ankle sprain, we're referring to the mechanism of injury. What he did was hyper-inverted the foot, so brought the bottom of the foot too far toward the midline. And then a lateral ankle sprain is referring to where the damage occurred, which is on the lateral aspect of the ankle, or a lateral aspect of the lower leg. All right, so what structures has he injured? So the things I want you to know, you have 3 ligaments on the lateral aspect on the outside of your ankle that help stabilize the combination of those talocrural and subtalar joints. And so those ligaments, if you view them like a clock face, sit at 3 o'clock for the first one, approximately 6:30 for the second one, and about 9 o'clock for the third one. So the first one is the anterior talofibular ligament. That's the one that's highlighted in green there for you. So the abbreviation, of course, is ATFL. So all 3 ligaments limit inversion of the ankle. And the ATFL also limits anterior translation, which means forward movement of the talus. And an important thing to know about the ATFL is that it is stretched, or it is taught, T-A-U-T, it is taught in plantar flexion. So if I plantar flex my ankle, then that ATFL is going to be tight. Okay, so it's limiting motion. The CFL, the calcaneofibular ligament, again, is the one at about 630, and that's the one that's highlighted in green now. And so it only limits inversion. And you can see it actually spans, it crosses onto the calcaneus, so it actually spans the subtalar joint, as opposed to neither the ATFL and PTFL insert on the talus, so they are primarily, they primarily restrict in the talar curvature. But the CFL limits inversion, inserts onto the calcaneus. And then the last one is the posterior talofibular ligament, or PTFL. So it also limits inversion, and it limits posterior translation, or backwards movement of the talus relative to the tibia. So the way that lateral ankle sprains work is that they typically sprain in order. So if you just like rolled your ankle a little bit, but you didn't hear and feel a pop, and it hurts, to put weight on, but you can actually wait there, that's a grade 1 lateral ankle sprain. And so you may have some point tenderness on the front part of your ankle. You may get some bruising in a day, and you may get a little bit of swelling, but it's not a ton, right? Again, grade 1 lateral ankle sprain. And so what you've done in a grade 1 then is you have stretched your ATFL. Remember that a stretch then is a sprain. You're stretching out a ligament. So you stretched out your ATFL. And so that joint is a little bit less stable than it was before. Now, if we increase the force, then we tear the ATFL. So if they really invert their ankle, they heard and felt the pop, they don't want to put weight on it, really severe pain, 8 out of 10, lots of swelling, lots of bruising, that's a grade 2 lateral ankle sprain. And so what they've probably done is they've ruptured their ATFL and they've stretched their CFL. So that's grade 2. And then grade 3, you've worked your way all the way around to the PTFL. So grade 3, which oftentimes is accompanied by a dislocation of the ankle, meaning that the talus comes out of the ankle mortise, you've ruptured the ATFL and the CFL and probably sprained the PTFL. So I think there's a quarterback for the Washington team this weekend dislocated his ankle, but I meant to go back. I forgot to look right before class. I meant to look and see if there's a video, but I don't know if he fractured it or not. I don't think it was as bad as Dak Prescott, but most of the time, if you get a dislocation of the ankle, meaning the talus again comes out of the mortise, then you're probably going to get a fracture of potentially of the lateral malleolus, and if at the very least, maybe the CFL pulls away, or maybe you get a compression fracture of the medial malleolus. So yeah, so those are our lateral ankle ligaments. Okay. Oh, you did the medial side. Okay. Okay. Like I saw on the ESPN scroll, and I was like, I can look at that. All right. So those are the lateral ankle ligaments. So let's talk about the medial ones. So there's 3 ligaments on the lateral aspect. There's 4 ligaments on the medial aspect. And so the 4 on the medial aspect are referred to collectively as the deltoid complex. And they're called the deltoid complex because they look like a triangle if you look at all 4 of them together. And so the Greek letter delta is a triangle, and so that's why they're the deltoid complex. It's a similar setup to what you have on the lateral aspect. You can see they're a lot broader. On the lateral aspect, the ligaments are pretty thin. They're much thicker on the medial aspect of the ankle. So there's both an anterior and posterior tibiotalar, which are pretty similar to the ATFL and PTFL, similar ideas. So all 4 of them are going to limit eversion of the ankle. They keep you from pulling your ankle laterally. But the anterior tibiotalar also prevents that anterior translation of the tibia. The posterior tibiotalar prevents that posterior translation of the talus, not the tibia. So both anterior tibiotalar and posterior tibiotalar prevent anterior and posterior translation of the talus relative to the tibia, respectively. So the one that's highlighted there is the anterior tibiotalar. Then we have the tibio-navicular. As you can see, it's a pretty broad ligament. So that's its primary job is going to be to limit eversion. Similarly, the tibio-calcaneal is there. I had to add a layer, but there's your tibio-calcaneal ligament, eversion. And then the posterior tibio-talar there limits eversion. So lateral ankle sprains, pretty common, right? It's one of the more common ankle injuries, or more common sports injuries. Whether you're talking about football, soccer, lacrosse, basketball, volleyball, any number of different running, sprinting, cutting sports, lateral ankle sprains are pretty common. Medial ankle sprains only account for about 5 to 10% of ankle sprains. Why is that? Why are laterals so much more common than medial? Yep. Yeah, certainly some of it deals with the sporting movement that we engage in, right? You stop and change directions. That's more of a pushing force laterally, and you're straining the lateral aspect of the joint. So some of it's that. Part of it too, though, is the difference in bone structure. So one of the things you can see here is that the lateral malleolus, the fibula, extends much farther distally than does the medial malleolus. And so from a practical standpoint, when I evert the foot, those bones, tails in particular, are going to bump up against that bony block of the fibula. So I can't really evert very far, and I have some bony protection there. If we go into inversion, because that medial malleolus is so much higher, I can go a lot farther into inversion, and you can see that on your own foot. Whenever you invert, you go way into inversion. You can't go very far into eversion, because on the medial aspect, you don't have that bony block because that medial malleolus is so much shorter than the lateral malleolus. So if I don't have a bony block, what has to stop that motion then is, well, hopefully first the muscles, and if they can't, then those lateral ankle ligaments. And it's easy for them to get overloaded. And so that's why the primary reason that those lateral ankle sprains are more common than medial is you just lack that bony congruity. And so the pressure then to stop that movement falls onto the lateral ankle ligaments. So you do get eversion ankle sprains. It is possible, like I said, about 5 to 10% of ankle sprains. Usually the mechanism there is the thing falls on the outside of your ankle and just kind of pulls your foot away from the midline. So oftentimes eversion ankle sprains, because of that bony block, are accompanied by a fracture. So typically the fracture is a compression fracture of the lateral malleolus. High ankle sprains, similar concept. So as mentioned earlier, a high ankle sprain is a sprain of the anterior inferior tibiofibular ligament, AITFL. And so what ends up happening there, the typical mechanism of injury is forced dorsiflexion. So the foot gets forced up into the ankle mortise and then rotated away from the midline. So that could be that somebody's accelerating, so they're over the top of that foot, and their foot is in dorsiflexion, and they rotate away from the midline. So for example, this is an old picture I've been using for a while, so I don't know who the ball carrier is. But on the right ankle of the Packers guy there, you can see his foot is in at least a neutral position, potentially some dorsiflexion, but it's being rotated away from the midline. So that's the typical mechanism of injury for a high ankle sprain. And so again, what ends up happening then is that if we force the foot into dorsiflexion and rotate it away, that's going to shove the talus up into the ankle mortise and then push it up against the fibula, and so then that stretches out the AITFL and can potentially stretch it out and sprain, right? And so if we lengthen this ligament here, holding these two bones together, what ends up happening is every time that athlete goes to push off into the next step, so when you go to push off, it's going to shove the talus up into that ankle mortise, up into that socket. And so if that ligament's sprained, that pushing of the talus up into that mortise is actually going to separate that joint between the tibia and the fibula, which again, ideally, we're not going to get motion there. But if we sprain that ligament, we are. And so every time they go to push off, it's going to separate that joint, and that's going to hurt quite a bit. In part because, remember, that interosseous membrane is there, so that membrane between the two bones, and that membrane has a really good nerve supply. So then every time they push off, it gaps that joint, it pushes the tibia and the fibula apart, stretches out the interosseous membrane, and that hurts quite a bit. One of the problems with high ankle sprains is that we don't have any muscles that pull those two bones together, right? So with a lateral ankle sprain, you are forced into inversion. Well, we have several muscles that are everters. So if we strengthen those muscles, we can reinforce that joint, and you can, again, stabilize the subtalar joint. But in the case of a high ankle sprain, there's no muscles that can do that. If you strengthen the muscles in the lower leg, it doesn't really stabilize the joint. And so high ankle sprains tend to be these kind of like nagging 6-week or longer types of injuries because of that. All right, so other joints in the foot. So there's the transverse tarsal joint. So that one has some other names. So it's also called the mid-tarsal joint. So the transverse tarsal joint actually includes two sets of joints. So the transverse tarsal joint, the posterior aspect is the talus and the calcaneus. And so the two joints of the transverse tarsal joint are the talo-navicular, so the interaction between the talus and the navicular, and the calcaneo-cuboid. So those two collectively are referred to as the transverse tarsal joint. Why does that joint matter? That joint matters because that's where we get what's referred to as abduction of the foot. You take your, easiest to look at the second toe. Take your second toe and we can rotate it away from the middle. So the way that that's done, the easiest way to envision it, and obviously we won't do it this semester, but the easiest way to envision it is basically you have somebody just kind of hang their foot off the table and you grab their calcaneus, their heel bone, and then you can slide their foot laterally, right? So that's abduction of the foot. So that is going to be a really important motion that allows the foot to I'm going to refer to it as unlocking. It allows the bones to slide apart a little bit, and that's an important part of weight acceptance during gait. So gait meaning walking or running. The foot has to go from being rigid whenever we initially hit and whenever we push off. We want a nice rigid lever. But in the meantime, in the middle of a normal step, we actually want the foot to, again, unlock a little bit to allow those bones to slide apart some. And that helps us accept weight, to spread weight across the ligaments and the musculature of the foot. And that then keeps a bunch of vibration forces from coming up the tibia into the femur. So that mid-tarsal joint then is going to be important for abduction of the foot. Yep. So separation too much there would be fairly unusual. Usually it's going to be a subtalar issue where they just, so for example, if somebody gets a medial ankle sprain, like, potentially the Washington quarterback got, which I call the outside of their ankle, oftentimes not only have you sprained one or more of those deltoid ligament complex ligaments, but there's also a ligament on the bottom of the foot called the plantar calcaneal navicular ligament. The spring ligaments, the more colloquial name for it. And so when you sprain that one, that really allows the subtalar joint to move laterally, and so that's when you get too much motion, and that really tends to affect foot motion. So it's usually more of a subtalar issue rather than a mid-tarsal issue. But one that is really commonly injured is the tarso-metatarsal joint. So tarso-metatarsal joint, or joints plural, so that's going to describe the interaction between all of the cuneiforms and their respective metatarsals. And then the cuboid over here and its metatarsals. So then the tarso-metatarsal joint is through here. Lisfranc injuries refer to injuries to that joint, but almost always Lisfranc injuries are injuries to the interaction between the intermediate cuneiform here and then the second metatarsal. So you have ligaments that actually run both between the metatarsal bases, so there's ligaments that sit in here, and then there's ligaments that run from the bases to the nearest tarsal bones. So in a Lisfranc injury, it's called a midfoot sprain. So what ends up happening there, it's a pretty common contact sport injury, but it doesn't have to be. It can basically just be a sprint sport injury. And so the common contact sport injury, because it's usually football offensive linemen or defensive linemen that get this, is that they are pushing off, so their foot is in plantar flexion, they're pushing off, but their big toe is extended, so they're on the ground, kind of like that, right? So they're pushing into the next step, and then somebody falls in the back of their leg, and so then when that happens, that's going to compress their foot and their ankle, and then typically that compression causes a buckling here at this joint, and so then that second metatarsal pops up. That can be an emergency in that you have an artery that runs right over the top of that. And so if you then impinge on that artery, you're going to cut off blood flow to your toes. As we know, anytime you cut off blood flow to a tissue, that tissue can die and then may need to be amputated in this case. So those can be emergent injuries. And so again, a Lisfranc injury is a sprain. It's almost always between here at the first metatarsal or at the second. But what happens there is that either of those metatarsals pops up relative to the tarsal. So you get that little gap Obviously, that changes the way the foot performs in weight bearing. And then the other thing is you can get a non-contact injury with that as well. So if somebody's pushing off really hard, basically that torque, that turning force that the calf creates at the calcaneus can then pull down a little bit too much if those tarsal bones are fixed into the ground, and that can cause a sprain of those ligaments as well. So it can be that you just pushed off too hard, if the calves are too strong, and you exerted too much force, you overcame the amount that the ligaments are able to resist, or there's that loading, that compressive loading whenever you're in plantar flexion with the metatarsal heads in the ground. So with those, almost always that requires plates and screws. So usually with the second metatarsal, they'll go through and actually put a screw between those two. But they have to go back and take it out. I forget how long it's in there. I think it's in there for like 4 months. But then they go back through and take it out because otherwise you don't get normal movement of the foot. You can't walk. So they wait for the ligaments to regrow as much as they can, or to repair themselves as much as they can, and then they take the screw back out. All right. So supination, pronation. We're going to talk about this a lot more next Monday, because next Monday is a one-day talk on gait, which again is walking or running. So two of the terms I'm going to talk about a lot are supination and pronation. And supination and pronation are combination motions. So they are motions at the talocrural joint and at the subtalar joint and at that mid-tarsal joint. So again, the interaction between the talus and navicular, and then calcaneus and cuboid. So with those, the thing I want you to know for now is that supination is synonymous, or think of supination as when the foot is locked. The foot is nice and rigid. So in this picture, so the important motions to know is that we associate supination with inversion at the subtalar joint and adduction at that mid-tarsal joint. So supination is inversion and adduction. And so if we invert at the subtalar joint and we adduct the foot, what that does is it brings all those bones, the tarsals and the metatarsals, nice and close together. So that makes a nice rigid foot. So for now, we're going to ignore dorsiflexion, plantar flexion, because that's where this gets confusing. So in supination then, you have a nice rigid foot. So during the normal gait cycle, when your heel first hits, and then when you push yourself into the next step, the foot is going to be in supination, meaning that the foot is nice and rigid. So we want it to be rigid when we first hit, and then it's going to move from being rigid and locked to loose and unlocked, kind of in mid-stance as you weight bear over the top of that foot. And as we push back off, the calcaneus moves back into inversion, which then relocks the foot. So probably the easiest way to envision this is as movement of the calcaneus, of the heel bone. So when you first hit, your calcaneus is inverted, and so then that's a key part of supination that pushes those bones together. As you move from what's referred to as heel strike, when your heel first hits the ground, to mid-stance, where you're standing over the top of that foot, the calcaneus actually slides a few degrees. I think it's give or take 5 degrees from inversion to neutral to slight eversion. And so as the calcaneus slides then into eversion, that's when we get pronation. So you can see pronation there, a combination of eversion and abduction. And so that's going to allow those bones of the foot to slide apart. So they then help provide some cushion and weight bearing. And then as we move, pick your heel off the ground, called heel off, your calcaneus then moves back into inversion, and that relocks the foot and helps you push off into the next step. So we'll talk about these a lot more next Monday, but just to give you a primer on supination, pronation. Probably if you've ever heard of those in the foot, you probably heard about it like when you're buying shoes. Like, oh, I'm an overpronator, or I'm a supinator, or whatever. That's usually where those terms come up. All right, a couple joints left. So we got the metatarsophalangeal joints. So obviously the metatarsophalangeal joints, there are 5 of them. So those describe the interaction of the metatarsal and the proximal phalanx. So the first MTP joint here is where we get turf toe. So turf toe is a hyperextension injury at that first MTP joint. And so why that injury is particularly disabling and particularly painful is because every time you push off into the next step, whether you're walking or running, you're going to hyperextend your big toe, which means you're going to push it back toward your head, and then your big toe is going to flex and help push you into the next step. So if you've sprained that joint, then every time you take a step, you're going to stretch out that sprained joint capsule, and it's incredibly painful. So it doesn't seem like, I don't know, for anything like me, the first time I heard a football player without a turf toe, I was like, hurt his Oh, but it is. And so, again, because you obviously can't walk or run if you can't push off, then that tends to slow you down quite a bit. So, turf toe then is an injury of the first MTP joint. And then we have our PIPs and DIPs, just like in the fingers. So you got our proximal, I'm on the fifth toe now, the proximal interphalangeal joint and distal interphalangeal joint of each of the toes. So pips and dips, PIPs are close, DIPs are far. And again, in the big toe, because you only have 2 bones, you just have 1 interphalangeal joint. In terms of arches of the foot, so there's 4 arches of the foot. The big one is the medial longitudinal arch. So if somebody says, oh, I got flat feet or I have fallen arches, they're almost always referring to the medial longitudinal arch. But obviously there's an interaction between the 4 of them. So the medial longitudinal arch is on obviously the medial aspect of the foot. It runs from the medial aspect of the calcaneus, so your heel, all the way through the calcaneus, through the talus, navicular, medial cuneiform, and then down to the head of the first metatarsal. That's your big arch of the foot, the most obvious of them. The lateral longitudinal arch, same concept, but on the outside of the foot. So it runs from the lateral aspect of the calcaneus to the head of the 5th metatarsal. So that one's pretty slight. There is an arch there, but it's not near as pronounced as what we get with the medial longitudinal arch. The transverse tarsal arch runs from the navicular over to the cuboid. So it's a side-to-side arch, and then, or medial to lateral arch, and then the metatarsal arch runs through the metatarsal heads. So that's also a medial to lateral. And so what each of those arches does is they help the foot conform to a variety of surfaces. So if you're, barefoot, moving along differently shaped rocks in a river, which is, for whatever reason, that's the classic example that different textbooks use. But your foot has to conform to a variety of different shapes. If you move from a rock to a tree branch or something, your foot is able to kind of mold to that shape a little bit. And that's because of the movement at the subtalar joint, also at the mid-tarsal joint, but then obviously that affects the arches. They can either raise or rise or fall, and then that helps the foot conform to those different shapes. So it helps give us some stability. All right, I think I bored you enough for today. So next time, we'll talk about the plantar fascia, and then we'll run through the muscles of the lower legs. So there's only 12 of them. So the good news is you only have 12 more muscles to memorize, and then you're done with muscles for the class. So almost there on that front. So in lab tomorrow, we're going to do, I'll break out the plastic bones and the plastic legs, and I can show you how to find any of those things if you're interested in doing that. If not, they'll see you on Friday, and we'll talk about all the, like I said, the bones or the muscles and the plantar fascia. So see you then.